feed off of one another, leading to the problems where the airways become more dilated and are sort of set up for this problem. And I'm going to talk a little bit about the potential targets for treatment and where we're focusing attention in the future on trying to get rid of what's going on. So in terms of the diagnostic part of this, I think after you have a high clinical suspicion, you really need to get a picture. That's ultimately what's going to lead to the diagnosis of bronchiectasis. Plain radiographs, chest x-rays obviously can show it if it's there, but it's very, very poor at excluding bronchiectasis. And even regular CT scans can sometimes miss things. So the modality of choice now, we don't really do bronchography anymore, but the modality of choice now is the high-resolution CT. And with that, having people with the inspiratory and expiratory images, as well as prone and supine positioning, can be very helpful in figuring out the diagnosis and looking for things that are very characteristic of bronchiectasis. So I think the number one thing that we typically talk about for diagnostic criteria from a CT scan is the diameter of the airway is bigger than the associated blood vessel that runs with it. That's the easiest one to kind of pick out. But tram tracking we hear about a lot, which is a failure of tapering of the airways, bronchial wall thickening, cystic dilation of the airways, all of these other things can also be seen. And here's an example of a CT scan of a patient that has a lot of these different features. Some of the lesser known discussed criteria are seeing an airway a centimeter from the thoracic wall is actually abnormal. That's one of the criteria that can be bronchiectasis, or seeing an airway that's against the mediastinal part of the lung. The tram tracks, again, non-tapering airways or airway walls that are very thick. And then the signet ring, again, is kind of the hallmark finding. Even though this isn't the best example of it, it's something that we see very commonly with bronchiectasis. And then air trapping is also pretty common in terms of findings on CT imaging. So bronchiectasis, unfortunately or fortunately, is associated with a huge laundry list of other medical problems. And this is one of the hard parts with treating bronchiectasis, is really understanding that, part of the treatment is really going to be focusing on what the underlying cause is. There are post-infectious causes, there's immune causes, there's structural abnormalities, there's inhalational injuries. All of these different things can play a role, but it's very, very important to try to track down the cause. And the reason why is if you don't treat the underlying cause, you may miss out on being able to make people better. So in terms of the workup, it's very important to kind of think about, with a good history and physical, and talking to the patient about what they've been around, what they've experienced over time, can try to help figure out which of these may be relevant. In terms of this kind of diagnostic algorithm, I think the first thing is really when you see the patient, talking to them and getting a really good history in terms of what they've been around, comorbid conditions, things like that, to try to get an understanding. And then obviously the picture is going to help us a lot. I don't get into much of this in the talk, but the location of bronchiectasis is quite important in terms of possible etiologies of it, meaning upper lobe diseases may be different than middle lobe and sort of perihilar disease and lower lobe disease. So let the imaging help to guide a little bit about what's going on. Obviously, lab testing is very helpful as well when you're looking for immune deficiencies or significantly elevated eosinophil counts or things like that, and the serologies to look for autoimmune diseases. Cultures, with the last talk, you heard a lot about NTM. These different bacterial presence can be the cause, but they can also be sort of sequela from having bronchiectasis, and so cultures are very important to follow over time. Pulmonary function testing, because it is an airway disease, typically shows obstruction. From a diagnosis standpoint, it's not quite as helpful other than to follow people over time, meaning you can have significant bronchiectasis that needs treatment with normal lung function, so don't let that be a reason not to dig deeper. But they can be helpful over time to sort of see how therapies are going, certain treatments, maybe looking at pulmonary function outcomes over time as well. And then when we're digging a little bit deeper into the causes of bronchiectasis, there can be a lot of syndromes that are associated with this. So things like Cartagener's disease or ciliary dyskinesia, again, looking for things in the sinuses, potentially looking for situs inversus. Aspiration is a huge cause of lower lobe bronchiectasis, and so swallowing studies can be helpful. Obviously, cystic fibrosis testing with sweat chloride, alpha-1 antitrypsin, and things along those lines. So in terms of treatment, this is where we really fall short right now. Right now, there are no approved treatments for bronchiectasis. For the underlying conditions, we do have some, but that doesn't really, treat everybody the same way. In the United States, we don't have our own guidelines, so we're kind of stealing recommendations from the 3 published guidelines, which are the BTS, Australia, New Zealand statements, and then the European Respiratory Society. And much of what we do in treatment, at least historically, has been based on cystic fibrosis and kind of adapted for bronchiectasis. And obviously, they're different diseases. So in some ways, we need to be thinking outside of the CF world to get into treatment options there. So in terms of what we're trying to do, this was highlighted on several talks, but get rid of the mucus in the airways. That's one of the paramount treatment recommendations, is really airway clearance, airway clearance, airway clearance. Ideally, over time, we're trying to decrease inflammation and then the infection piece of this vicious vortex. And with that, we're hoping to mitigate the structural lung disease that can develop. And when that structural lung disease is there, patients have higher risks of exacerbations, more symptoms, and quality of life significantly goes down. So right now, in terms of how we treat things, really I think one of the most important things with bronchiectasis, similar to the NTM discussion, is having good discussions with the patients so that they understand what's going on and the importance of the treatments that we're using, because this is really a lifelong thing. Once they have bronchiectasis, they're going to be dealing with it for pretty much forever. And so it's really important to set the expectations of what we're trying to do with treatment, how important it is to stay up with it, exercise, these sorts of things. The next 2 kind of buckets I put into cause-specific and cause-agnostic treatments. Again, cause-specific will be related to things that we are able to diagnose. And then the cause-agnostic treatments are things like airway clearance, treating infection, things that really happen to everybody with bronchiectasis. And it doesn't really matter how you got there. You need to focus on trying to get things better there. And then obviously having conversations with your patients about how we want to monitor things. What is considered success? How we follow people? How frequently they need to be coming in, and those types of topics. So in terms of the underlying cause, obviously if you have ABPA, you're going to treat ABPA. If you have an alpha-1 antitrypsin deficiency, you're going to give replacement therapy. Treating aspiration obviously is very important as well. And the rest of the diseases, again, I'm not going to focus on those specific treatments, but it's really important to deal with those, because if you don't, you're not going to get ahead of the disease. Airway clearance, again, very nice talk by Ashwin on Saturday, I think it was, and so I won't go into this specifically, but other than to say, if you have bronchiectasis, airway clearance is part of the regimen no matter what. And again, there's a lot of different modalities for this, tricks and tools that people can do, but it's very important to do. And there's the mechanical versions of airway clearance as well as pharmacologic airway clearance. The most common medications right now, obviously, we use are hypertonic saline. Mannitol, maybe in certain circumstances, can be helpful, and people use acetylcysteine. But in larger studies, really, nobody has been able to show that these medications, one is better than another. Bronchodilator therapy may be helpful as well. And then a couple of things to avoid in these patients. If they don't have cystic fibrosis, don't use Pulmozyme. That actually was borne out in a study that was done several years back that basically showed that people had worse outcomes if you use Pulmozyme. Inhaled steroids, as we just heard in the last talk, may not be a great idea because of the amount of bacteria in the airways and the relative local problems that people will get in the airways with immune suppression. Although if they do have an indication for inhaled steroids, they may need it. Again, asthmatic patients, sometimes people with high eosinophils, things like that. And then long-acting bronchodilators haven't really shown to be of much benefit in these patients either, unless they have disease where it would be beneficial specifically for that. Macrolide therapy is kind of an interesting one. This has been sort of a thought of an early anti-inflammatory for the lungs. Part of the use of macrolides in bronchiectasis is really not the antibacterial effects of it, it's more of the anti-inflammatory effects. And there have been a few studies that looked at outcomes in patients that were treated with macrolides if they had frequent exacerbations. And it did seem to reduce the number of exacerbations, delayed times to first exacerbation, and improve quality of life. But resistance in bacteria did get a lot worse. Obviously, if Mycobacterium is there, it's a no-no. You don't want to be giving people azithromycin by itself because that is one of the cornerstones of that treatment. So back to some other targets, and what I'm going to focus on really is this inflammatory kind of area right now, really the neutrophilic inflammation that develops locally in the airways. And with that, neutrophils, they have a lot of, obviously, things that are designed to cause havoc and kill infection and get rid of problems in our body when we have bacteria that's there. But the problem is in the airways with bronchiectasis, it's kind of an over-exuberant response. And they are the predominant inflammatory cell, obviously, that gets into the lungs in people with bronchiectasis. And they release these things like neutrophil elastase and other chemicals that can cause a lot of inflammation in the airways. And so it's been thought of as a target of treatment and something that if we can decrease sort of that neutrophilic response in the airways, maybe we can decrease the overall inflammatory milieu. With that, there's less inflammation for bacteria to kind of cause the problem as well. A little bit of flow charts in terms of targets here. One area for treating inflammation has been really focusing on trying to decrease that neutrophilic piece. And as we all know from medical school, the neutrophils are made in the bone marrow. They sort of develop and mature in the bone marrow. And one of the things that happens is dipeptidyl peptidase or capsaicin is actually something that kind of leads to the maturation where these granules get full of serine proteases and things that get released once they get to the site of action. And so areas where people have looked at from a treatment standpoint is how do we either get neutrophils down, the number of neutrophils down, or can we make them less intense in terms of their response when they get through the bloodstream and then into the airways and cause their normal actions. And all along this pathway, there have been different trials trying to figure out early phase, I shouldn't say clinical trials, but early phase testing to see if there may be areas for therapeutics. And with that, I'm going to talk about one of the few trials that's actually been done recently with a disease-specific thought in mind, which is dipeptidyl peptidase, which is the inhibitor called brensocatib in bronchiectasis. And the WILLOW study was actually published a couple of years ago. It was a phase 2 study of this reversible inhibitor that would actually decrease the activity that led to the maturation of the neutrophils. They used a couple of different dosing regimens and compared it against placebo. And they followed people that tended to get sick. So people that had at least 2 exacerbations per year over the course of 24 weeks. And the goal of the study was really to look at exacerbations and to see could we decrease the frequency of exacerbations by using this medication. And so this is the kind of breakdown of the patients and the timing, but they had, in addition to the exacerbations, they had some secondary endpoints, which were quality of life measures, change in FEV1, and then they were looking specifically at the neutrophil elastase activity to see that the drug is doing what it's supposed to. If it decreases the activity of neutrophil elastase in the airways, then the drug should be doing what it's supposed to be doing, and with that, hopefully tying to the exacerbation frequency going down. So what they found is that it actually worked reasonably well. In this graph over on this side, the placebo group is the purple, and this is exacerbation, time to first exacerbation. And the two different concentrations of the drug are up here, and you can see that people exacerbated earlier if they did not receive the medication. They exacerbated later if they did. And then I want to highlight the bottom panel right here. With each dose, again, placebo being on the top, 10 milligrams of brensocatib here and 25 milligrams here, there was a dose-dependent decrease in the amount of neutrophil elastase in the airways. So again, the mechanism being decreasing the effect of neutrophil elastase, and then the outcome being decreasing exacerbation frequency. So with that positive early study, phase 2, they've done a phase 3 study that actually is closed. The early reports are that it was actually very favorable. And so hopefully we should be getting a peer-reviewed article about this pretty soon. But basically the phase 3 study, in the data that's been shared by the company who makes the medication, showed a similar thing. There was a decrease in exacerbation frequency. There was actually a slight improvement in lung function, quality of life improved. So the early data from this is very, very favorable. And now we may actually have a treatment that's designed for bronchiectasis regardless of how you got there. Now I should say there were a lot of exclusions in terms of the people that were in here. This is non-CF bronchiectasis. These are people that did not have active NTM disease and were not sick with infections when they were enrolled. But it decreases that inflammatory milieu in the airway and helped a lot. There's another trial that actually is closed for enrollment, but the data we're still waiting to get out, which is looking at people with eosinophilic predominance in the airway, and benralizumab, looking to see if they had improvements as well. Some of the early sort of case series showed that if you decrease the effectiveness of the eosinophilic pathway, you might also have some benefits in the airways. So here's where we are in terms of the clinical trials that are going on now. This was actually published just in May, right ahead of the World Bronchiectasis meeting this summer. And they're targeting really, again, I think we're finally getting some trials that are looking specifically at bronchiectasis and what treatment options we might have in terms of focusing on neutrophilic inflammation, looking at the eosinophilic pathways. There are trials looking at mucus clearance. I mentioned this with the CF talk as well. There's some potentiators that might work, as well as other medications to try to help with clearing the airways from medicines that are different than hypertonic saline and N-acetylcysteine. And then obviously medications to try to treat the infectious components of bronchiectasis. So in terms of just the key points that I want to mention at the end of the talk is really bronchiectasis is a very large group of diseases that are kind of a final common pathway into airway remodeling, infection, inflammation, and symptoms. I think history and HRCT are obviously really important to figuring out what's going on, and then focusing the evaluation on what other things may be affecting the patient. Treatment now is really focusing on the things that we can do, which is clear the airways, get the mucus out, treat infections, treat exacerbations, and hopefully with the advent of these newer medications, particularly the ones to decrease the inflammatory pathway and the neutrophilic pathways, we actually might have something coming out soon that will give us some options to treat bronchiectasis with different medications regardless of the cause. And that's all I have.
Great, fantastic. This built on Joe's talk. What Joe talked about was really MTM. But this is a broader talk in relevance to what I see. I see more bronchiectasis non-TM.
Yeah, right.
That's a real struggle for me. So the fact that we can target the cell that's causing damage, that is the neutrophil, in a productive way is really, really exciting. So the other thing I'd like to highlight, and even though I'm in an academic center and a tertiary center and I see these patients, it's abundantly clear to me, and I'm sure you'd embrace this, Jeff, it takes a village to treat patients with non-TM non-CF bronchiectasis. And often, when we're in our offices trying to slug away at it by ourselves, we really have both hands tied behind our back. We need respiratory therapists for mucus clearance. We need the support of a village to take care of these patients.
Yeah.
Thank you for a great talk. So, just one clarification. So, the neutrophil, the drugs that the neutrophilic pathway affecting, you are going to start them right when you think that you are still in the process of making a diagnosis of bronchiectasis, or you have to make sure you clear out all the other etiologies and before you start it, and you know it's idiopathic or we don't know what it is for now?
Right, that's a great question. I think unfortunately, the only studies that are really going to be published soon are ones that are frequent exacerbators. So I think that at least early on in the use of these medications, once they get approved, it's going to have to be probably a little later in the pathway. But I think your point is very well taken, that the important time to treat is before you get tissue destruction, before you develop more significant bronchiectasis. And so I do believe that there is likely a place for this very early in the treatment algorithm once we find people that have bronchiectasis. There have been some small studies of brensocatib in CF, and it actually works in that disease as well. They found the same things that they did in the WILLOW study. So I think that regardless of the cause, if you can decrease the inflammatory effect of the neutrophils in the airway, you're going to lead to improved outcomes. So over time, I hope we get there.
Nick and then us.
Yeah.
Very nice talk. Is there a role for CFTR modulators, non-cystic?
Yeah, I think and I mentioned this a little bit before to a smaller group that I was talking to, I think so. I mean, in my mind, one of the biggest improvements in outcomes can come from airway clearance, and sometimes with the, CFTR is really trying to hydrate. If that's working well, it's trying to hydrate the mucus, thin the mucus that way. So it may be that the addition of a medication that sort of rehydrates from the inside, it sort of replaces the need for hypertonic saline. I don't know if that's true or not. Obviously, that's very theoretical, but there are some trials looking at modulators to try to fix CFTR function and see if that will improve outcomes.
You know, Nick, if we think of therapy with regard to imagery of buying a car, what we started with was a Toyota. If we now increase with CTFR modulators, we're into the Lexus. And then if you add this therapy on, we're definitely Lamborghini. So I think what we have to do, we would love to try these, but we are not in control all the time. It's going to be managed care and our ability to really advocate for the patient. Last question.
Yeah. Hey, Anas.
So, Jeff, you mentioned briefly some of the results, although not published, of the ASPEN trial about some outcome on lung function. So, are we going to have a modality that might actually change the natural history of the disease?
Yeah, that's the hope. I mean, I think, at least according to the company that makes this medication, they are in the process of applying to get this looked at by the FDA. And so I think that once that's out there, this is really an attempt at disease modification in bronchiectasis, regardless of the etiology. And I do think it can be a disease-modifying agent for bronchiectasis. We don't have that now. So this is really our first opportunity, and hopefully it's successful.
All right, another round of applause. That was sponsored by Instameds, and we do appreciate our sponsors. Our next talk is on the emerging role of activin signaling inhibitor therapeutics to improve outcomes for patients with PAH. I'm pleased to introduce Samantha Gillenwater, is Director of the Medical ICU, Pulmonary Critical Care Medicine in Western Florida. Samantha, it's all yours.
Thank you very much. It'll take 2 seconds to figure this out. All right. So I just want to say thank you for inviting me here, and thank you to Dr. James Klinger. He's the one who provided these slides for us to go over today. So the objectives of what I'm going to talk about today are just to review some of the modulatory role of TGF-beta signaling pathways in the pathophysiology of PAH, and look at the findings of recent clinical trials of the activin receptor type 2A ligand traps in pulmonary arterial hypertension, and then how to utilize the adapted treatment guidelines to understand how these agents should be used in the management of pulmonary arterial hypertension. Just as a recap, I know that we had some lectures earlier on the course, but so looking at the normal pulmonary pressures, they're listed here, but to remind us kind of what we're looking at and how we are, there's a lot of different nomenclature when we talk about pulmonary hypertension, pulmonary arterial hypertension, but these are some of the things that we look at. So the mean pulmonary artery pressure of greater than 20 at rest is how we just diagnose simply pulmonary hypertension. Do you have elevated pressures in those vessels? 21 is actually greater than 2 standard deviations above normal, so that's where we get the greater than 20 in the guidelines. Pulmonary arterial hypertension is looking at, when you're looking at the wedge pressure of less than 15, along with your mean pulmonary artery pressure greater than 20, and then your PVR of greater than 2 Woods units. And this is reflective of the most recently published guidelines, which are a couple years old at this point. Some of the other things that we look at, you're going to be looking at your transpulmonary pressure gradient, and then the diastolic pressure gradient. And this just gives us a lot of information about what side of the system that we're looking at and help us to tailor and diagnose which group our patients are falling into. Why did we pick a mean pulmonary artery pressure of 20? These are some of the changes in the guidelines. So a lot of people keep saying, you know, why do we keep changing these numbers? And of course, it's with more experience and people getting together and looking at where we see any kind of mortality increase. The thought is if you get people diagnosed earlier on with some of these minimal changes, then we can discuss maybe starting treatments and getting them their pressures down quicker. So this kind of shows us just about as the mean pulmonary artery pressure starts to increase, you start seeing increase in mortality, and this is where we dropped the mean pulmonary artery pressure from 25 in the old guidelines down to 20. This is all based on the 6th World Symposium of the Pulmonary Hypertension. These are the most recently updated groups for pulmonary hypertension. I'm really going to be focusing in on Group 1, pulmonary arterial hypertension, and depending on the last time that you really reviewed some of these things, some of the subgroups have moved around a little bit, but this is really helpful because this affords us the ability to know what treatment options we have available to treat our patients. So it's really important for proper diagnosis because we know that there are certain medications that are used in different groups that can actually cause harm. So the first thing is to diagnose them correctly with pulmonary hypertension and then figure out which group they would fall under. So group 1 versus 2, 3, 4, 5. And then you can just see how many treatment options there are available as far as medication management and where there are not really many crossovers in between. So that's why it's really important that you're not treating someone with, let's say, group 2 pulmonary hypertension with some of the options that we have for those in group 1. So here's not a completely inclusive list, but this is a pretty good summary of all the things that we have available to us from the last guidelines that were published thus far. And then just focusing back on reminding us that the WHO Group 1 is pre-capillary. Again, there's a lot of nomenclature changes, and this is where we start talking about things. But looking at the pulmonary arteries before they reach into the capillary system, that's where we're really talking about and focusing on the elevated pressures there. These are the current drug classes for PAH therapies and when about they were approved. And you can see that this list is growing and growing all the time. But if you look in between 2015 and now 2024, there was almost a decade in between where we had any new medications that were approved for this rare disease. So that's kind of what we're going to be focusing in on and looking at the process of why this is a new pathway that we're looking at. So some of the rationales for pulmonary arterial hypertension therapies, there's patient and animal modules are suggesting a decreased expression and synthesis of vasodilators or an increased expression of vasoconstrictors. So looking at those pathways and trying to figure out how we can kind of combat that and reverse those problems. Here's the 3 original treatment pathways for pulmonary arterial hypertension, and this is probably what a lot of us have looked at and gone through and figuring out all of the different medications that are available. There's the endothelin pathway, which looks at endothelin 1, and this is where we have our ERAs, or endothelin receptor antagonists, and that's the pathway that they try and target. Again, all of these are trying to help really open up those vessels and decrease the pressure going through. The nitric oxide pathway, where we get our PDE5 inhibitors and our soluble guanine cyclase stimulators as well, again working on this to help open up those vessels. And then the prostacyclin pathway as well, with prostacyclins and the derivatives, and again all focusing on opening up those pathways so the blood flow is going through easier without having high pressures there. Looking at what leading into why did we look into another pathway and where are we getting some of our new clinical research and data from. The TGF-beta is has three known subtypes in humans. That's TGF-beta 1, 2, and 3. And these play a critical role in tissue regeneration, cell differentiation, embryonic development, and then regulation on the immune system as well. There's numerous TGF-beta-like proteins and receptors that bind and work in a similar manner. So there's a lot of different things that we need to look at here. The superfamily includes 33 ligands and over a dozen of TGF-beta receptors and co-receptors. I'm not going to give you guys that extensive list now because I think that you'll all fall asleep by the time I'm done with that. But just knowing that this is a pretty complex and a very robust superfamily, that there's a lot of different things that we are looking into and that we have to look into. Focusing on where we're going to focus today and looking at. So there's two major TGF-beta signaling pathways. Ligands and receptors that will activate your SMAD2/3 there on the left-hand side, and then ligands and receptors that are going to activate on the other side, which is the SMAD158. And as you can see, both sides, so the SMAD2/3 or SMAD158, are going to bind the SMAD4, forming a multi-SMAD complex that can regulate gene transcription. They activate different gene programs. SMAD2/3, when it's combined to 4, is going to activate different gene programs. But you can see that there's a lot of crossover and nomenclature here, but this is how we're going to start learning. There's another slide here that I wanted to show, and it really kind of just displays the complexity of the TGF-beta signaling. There's a high degree of promiscuity in ligand-receptor interactions. You can see that one BMP ligand can signal via different type 1 and 2 and type 2 receptor pairs, and the same type 1 and type 2 receptor can mediate signals from different ligands. So it's a pretty complex flow through that you can see here. And a lot of times at the end of the day, we're looking at what the transcriptional response is going to be. The BMP signaling can also be modulated by extracellular inhibitors, which are called the ligand traps, which are going to limit ligand availability to those receptors. Cell surface co-receptors, which these are also called type 3 receptors, can modify the ligand receptor interaction. So my point in showing you this, a little bit of a busy slide, is kind of help break down and show you all of the different things that need to come together to interact with the receptor and all the downstream signaling that can happen, and also that there is some overlap. So there's a lot of things that go into this. So overall, the main point of this is that TGF-beta signaling is highly determined by local concentrations of the ligand and then the receptor. Transforming growth factor beta in PAH is important too. So mutations in BMPR2 are linked to familiar pulmonary hypertension. These are one of the first and the most populous, I guess, the most well-studied things that we see. About 80% of patients who have familial pulmonary arterial hypertension have this mutation, and even 18% of patients with idiopathic pulmonary arterial hypertension are going to have these BMPR2 mutations. Some of the additional mutations are being seen BMPR1 and then co-receptor endoglin, BMP9, and SMAD9. So again, these are the things that we're kind of looking into and figuring out that it's not only with familial PAH. little bit more on signaling, and then I promise I'll get you guys through the basic sciences of this. But so you have BMPR2 expression and SMAD158 activation are decreased in patients that have PAH, even in those that do not have the BMPR2 mutations. The activin receptor 2A expression and the SMAD2/3 are increased in pulmonary arterial hypertension. So it's important to kind of remember this and understand why we looked into what we are looking into for a new pathway. BMPR2 signaling suppresses the endothelial cell apoptosis, migration, proliferation, angiogenesis, and inflammatory responses. And the activin receptor 2A signaling promotes cell growth, differentiation, apoptosis, fibrosis, and inflammation. So all of this to say, all of these pathways, is there a way for us to stop this from happening? Is there a way for us to help out with these arteries that are becoming tighter and tighter or more constricted and causing those elevated pressures? So this is one of the studies that was an animal study to begin with, looking at the activin receptor 2A, rebalancing the activin versus just BMP signaling in pulmonary hypertension. So these are some of the initial animal models, and when we started seeing that these vessels were becoming more open or more patent, and based on changing some of this downstream signaling, we said, is this going to start working in humans too? So this is one of the early on things that were looked at in animal models. Sotatercept, this is what we're going to be talking about a little bit in the next part of this presentation, is a recombinant human activin receptor 2A IgG1 fusion protein. The way that it works is it's going to be trapping the activins and growth differentiation factors and affording us to rebalance the signaling in the pulmonary artery wall as well as the right ventricle. So you can see that it's an anti-proliferative function of this medication, where it goes and it blocks the downstream signaling pathway for these things. This is looking at activin receptor 2A in different animal models and comparing them to some of the other medications that we have, some of your endothelin receptor antagonists as well as the PDE5 inhibitors. And you can see here that there is, depending on which study that we're looking at, you can see that there is quantitatively more potent response than your standard of care single therapies when they looked at these, and as well as looking at the combination therapy. Not as much on the right side as you can see, but you can still see that this one medication is making a big response to these pathways and helping the pulmonary artery walls. I'm just reminding you about our REVEAL score. There's a couple different risk stratifications that we can use to kind of help keep track of our patients. This is the REVEAL 2.0, and reminding us that, you know, if you have a 0 to 6, you're in low risk category, intermediate, and then anything greater than or equal to 9 is, and you put yourself in the high risk. I'm gonna take a side step here just to talk about a case, and then I'm gonna keep going, and then I'm gonna ask you guys a question at the end of this. So I'm going to present to you guys here Miss Carey. She's a 50-year-old female. She was diagnosed with pulmonary hypertension about 2 years ago, and at that time her functional class based on her symptoms was 3. She was started on a PDE5 inhibitor and an ERA, and after that her functional class dropped to a 2. She was on 2 liters with exertion for most of that time. She comes in to see you after about 6 months ago. She has labs, she repeated pulmonary function test, she did her 6-minute walk test, and looking at her oximetry with ambulation because she's complaining of more shortness of breath. No change in her weight, and her vital signs are there. She's normothermic, blood pressure is 112/60, heart rate is 76, and she's 90% on 3 liters nasal cannula. I put this table here just so that you can kind of see the progression of how she started with us at a functional class 3 with her REVEAL score being a 10, placed in high risk category. And I'll say this about myself, but you know, in theory you talk about should she have been started on something else, but we chose to start her on dual therapy, and a year later we looked at her again. Her reveal score risk category came down to a 6. 6 months ago, she was creeping up to a risk category of about a 7, and now today she's more short of breath. Functional class is increasing. 6-minute walk distance has dropped about 90 points, which is significant. And her reveal scores puts her in the 8 category. So still within intermediate, but over the last year, you can really see that that's been progressing. So looking at sotatercept and how this pathway and how this medication, how we started looking at this. It was about a 24-week multi-center phase 2 randomized controlled trial. About 106 patients. Patients had a functional class 2 or 3, and they were either given placebo, sotatercept 0.3 or 0.7 every 3 weeks. And looking at their primary endpoint, which was their change in pulmonary vascular resistance. So you can see on the left side, the placebo didn't really have much change, and then 0.3 had a significant change, and then 0.7 even more, which that's how they got approved for their phase 3 trial, which is where this got their FDA approval for this medication. This was another 24-week multi-center phase 3 trial, given patients a subcutaneous injection of sotatercept 0.3 to 0.7 as tolerated every 3 weeks, and looking at their primary endpoint change. And we had some pretty good change from their baseline and evidence for this medication. Some of the side effects or the adverse events, I should say, there was, you can see sotatercept on the left, the placebo on the right, looking at any related to sotatercept in particular, and then leading to either discontinuation of the medication or withdrawal from the trial. The biggest ones that we really looked at here were increase in the hemoglobin level, thrombocytopenia, and some bleeding events. And those were the major things that were coming from the trial. There's a couple case reports of patients who had to be hospitalized for GI bleeding, that when we withdrew the medication, then that problem resolved essentially. So coming back to Ms. Carey, I just put the question here as she's still an intermediate risk factor. There's a lot of different options on the table as to what we could potentially do for her as far as additional therapy. She's obviously heading in the wrong direction with her risk category going up and up. So things that we need to think about, I just wanted to make clear that, sotatercept, something new on the market, you have to pick what's best for your patient. But it could be another pathway that we can address in trying to help these patients decrease their risk category, which is very important for mortality overall. So this is a diagram that Dr. Klinger put together, but it's basically just adds into sotatercept to how we are doing per the guidelines that we have most recently published. So again, just remember you do your vasoreactivity testing on your right heart cath. If they're responsive, it's calcium channel blocker. If they're not, then you go down based on whether their risk category is low, intermediate, or high. High risk, you're going to be starting, dual therapy with your parenteral prostacyclin, and then reevaluating rather frequently so that you make sure that they're not getting worse and that you are making them better, which is very, very important. This is just another trial, and there's a lot more up that I didn't go through all of them, not to bore you guys, but there's a lot more trials looking at this activin 2 receptor and looking at ligand traps to try and decrease or downregulate that further downstream signaling pathway to try and help these pulmonary arteries as well as the right ventricle wall. So in summary, my key points are really just saying that, one, you need to make sure that you properly diagnose your patients. Choice of initial treatment is really going to be based on their risk scores, whether you use Reveal, Compare. There's a lot of different ones that we can use. But we really should be starting most patients on combination therapy and keep in mind this new pathway. So we have 4 pathways now that we can address and trying to improve the pressures that are there. And that's it, just putting up here the reminder of some of the side effects because different from the rest of the medications that we have available to us.
Sam, great job. Wonderful, very focused. A couple editorials here. There was a lot of self-signaling in the last hour. And the reason that's so important is that we're understanding the fundamental signaling processes that lead to changes that are pathogenetic in a variety of diseases. So that's why this is hot. In pulmonary hypertension, a disease of dysfunction of smooth muscle, vascular, 3 of our therapies were targeting the pressure side of the game. But the disease is about the growth of the muscle. And actually, when that muscle grows, it contracts less. So what we're asking of 3 pathways is to improve something that's hard to improve. This therapy is the first therapy that's going to address the proliferative side of the lesion in pulmonary hypertension. That's why this is so different than all the others that are trying to correct the blood pressure problem in the lung, where the pressure can only be changed so much because you got thickness in the wall that causes resistance. So just an editorial, we want to thank Merck for sponsoring this. Yeah.
A quick question. Once you have diagnosed and started them on therapies, how do you normally, what is your protocol for following them? Do you just, after that, you do right heart cath every time, or you do just echo and try to, adjust that?
I think it's patient specific, honestly, and I'm sure every practice does it differently. I usually typically, once I start medications on my patients, bring them back rather quickly, whether it's within a month or 2 after starting, with repeat risk stratification things. So echo, 6-minute walk, some labs, things like that. If they're able to tolerate those medications, then I keep going and either add another therapy, a triple therapy, and see how they're responding to the medication. If I'm confused as to why they're not responding or the numbers are not adding up, then at that time I would repeat the right heart cath for more information, absolutely.
Samantha, thank you so much. Wonderful talk. All right, we have last but never least. Anytime I introduce my colleague Nick, it is just fantastic. He's Director of Airways Clinical Research Center, Professor of Medicine, a renowned expert in asthma, COPD, clinical management from Baylor College of Medicine. Nick, take us home.
Thank you so much for sticking around. I'd like to thank Dr. Panettiere and academic CME for inviting me to be a speaker. I know it's the last talk of the weekend, and you can see I'm very happy that COPD was highlighted in this meeting. This is the 4th talk. I gave 3 of them, and Dr. Make also gave 1 on COPD. But I'm going to highlight in this talk a few things that are different in a way. As clinicians, we certainly are looking forward to all these new targets for therapy, and we talked about that yesterday. But there are a few things that actually are key as clinicians that we sometimes sort of zip over, particularly when it comes to patients and choosing the right delivery system and right inhaler. We're going to talk about exacerbations and how can we prevent these. These are important problems. These are my conflict of interest statement, and nothing on this slide will influence my talk today. My ambitious learning objective, I'm going to talk to you about some maintenance therapies and how we use these therapies in preventing exacerbation of COPD. We'll talk briefly about some clinical trial data, highlighting the role of long-acting antimuscarinic agents in the management of COPD. And then at the end, but last but not the least, I want to talk about how do we personalize approach to patients with COPD when it comes to choosing the right therapy for the right patient. So let's start with the case. This is Bob, fictional case, but not very far from reality. This is a 72-year-old white man who is a current smoker, complains of chronic cough and sputum, has recurrent respiratory infections, has required hospitalization in the past year, and this is a red flag. I hope you agree with me that when a patient with COPD gets admitted, this is a red flag. We'll talk about that. He has comorbidities, hypertension, but well controlled, complains of reduced ability to move around, and has shortness of breath. You can see his FEV1, he has moderate airway obstruction, but he is very symptomatic. He's currently on ICS/LABA, which he takes twice a day through a dry powder inhaler, and he uses his MDI albuterol on a when-needed basis, but he admits that he's been using it very frequently. So this is a patient who is obviously uncontrolled, or you can call it not stable. We use control more for asthma, but now actually we're using the control for COPD as well. But based on his CAT score, he is very symptomatic. He has a history of exacerbation, not only exacerbation, but one hospital admission for COPD. We've talked about exacerbation this weekend, but let me remind you, exacerbations are not just a one episode and one thing that happens and that is it. It's actually associated with a subsequent risk of exacerbation. It's associated with increased risk of lung function decline. It's associated with other comorbidities, including cardiovascular, not shown on this slide. There's a very good link between acute COPD exacerbation and increased cardiovascular morbidity. But we also know that there are several triggers for exacerbations, which we're not going to talk about today, but these are important. Obviously, the most important is exposure, smoke, and other triggers, as well as infections, very important. Thus, vaccination is very important. I showed this slide yesterday, but I'm going to show it again, just to remind ourselves that managing COPD takes a village, but also we have several goals of management for COPD, including improving symptoms, improving exercise tolerance, lung function, quality of life. But we also want to reduce risk of exacerbation, hospital admission. We want to decrease risk of progression of the disease, and obviously mortality. Let's remind ourselves this is the 6th leading cause of mortality in the United States, 3rd leading cause of mortality around the world. So, and when it comes to management, it really does take a village, not just from the teamwork. It's not just physicians, but clinicians and PAs, nurse practitioners, respiratory care, pharmacists, nurses, and the patient and the caregivers. But also, when it comes to therapy, there are multiple modalities, the non-pharmacologic modalities, and of course, the pharmacologic modalities. And of course, physical exercise is very, very important. Let's review some of the things that GOLD strategies suggest. Well, obviously, for non-pharmacologic therapies, for every one of them, we need to work on getting them to stop smoking. Yes, I know it's a hard task, but we need to keep that in mind every time they come in. Recommend physical activity and, of course, vaccination. You can see the vaccination list continues to increase as we encounter more and more infections in these patients. Of course, for patients who are more symptomatic, and I'll talk about B and E, smoking cessation, but pulmonary rehab, Dr. Make yesterday has really put a very important push for pulmonary rehab. And I know when it is available and it's reimbursable, you really need to think about it, as well as obviously physical activity and vaccination. Just a reminder, when it comes to GOLD, they suggest that we stage the disease based on lung function, GOLD 1, 2, 3, and 4, based on FEV1 post-bronchodilator. This may change, as we know, and we talked about yesterday, that lung function may not be the only way to diagnose COPD in the next few years. But right now, that is what we use to diagnose COPD and stage it. But when grading lung function is sort of put on the side, and symptoms are very important, and risk of exacerbation. And the grading is between A, B, and E, and according to that, pharmacologic therapy is advised. We have a list of medications, currently existing medications, whether it's a short-acting bronchodilator, long-acting bronchodilator, combination bronchodilator, and now inhaled corticosteroid combination. And of course, we have some oral agents as well. Now, obviously, this can get very complicated, but one of the things I want to highlight on this slide is that the delivery systems are not the same. And yes, as clinicians, we're sort of more interested in the chemicals, in what medications we give to the patient, but we sometimes forget that the delivery makes a difference. A few years ago, I worked with CHEST, and we had actually surveyed pulmonologists and primary care. We published this in COPD, Journal of COPD Foundation. It's interesting, and again, I don't want to point my fingers to our primary care colleagues, but actually including us, we asked several questions, and you can look at it. It's a survey, so surveys have always to be taken with a grain of salt. But even in that survey, we found that us, as pulmonologists, we don't take time to think about the delivery systems. Even for patients who are admitted to hospital, we discharge them often on the same medication they came in with. And if they don't know how to use it, we assume they do, then we start jumping to a different medication. Before we actually go back to the basic, is the patient using their inhaler correctly? Is he taking or she taking it? And we'll talk about Bob in a minute, but again, to remind you that there are different modalities. Right now, mainly 4 modalities of delivery systems: the dry powder inhalers, the meter dose inhalers, which are the most common, the soft mist inhalers, and we only have few drugs in the soft mist inhaler, and of course the nebulization, which in patients who are elderly, who have cognitive dysfunction, dexterity problems, coordination problem, nebulization may be the way to go, although we don't have too many drugs that come in a nebulization platform. So when it comes to medication, we always have, as clinicians, to balance risks and benefits. Obviously, we want all the drugs to have the benefit and the least amount of risks, but many of these inhalers have side effects, and you have to know your patient, and not every patient is the same like others. So there are potential risks and potential benefits when you choose an inhaler device. What about pharmacologic therapy? How does GOLD want us to use it? Well, this is how they tell us. And every November there's an update in GOLD, and they may add more as we have new drugs coming. But currently, Group A patients who have minimal symptoms and no risk of exacerbation, a bronchodilator, doesn't tell you which one. You can choose whatever, short-acting agents or a long-acting, but long-acting agents are preferred, are enough. In Group B patients, currently GOLD suggests a combination of a LABA/LAMA or a LAMA alone, actually, if they're symptomatic but no risk of exacerbation. However, in patients who are in Group E, those with 2 or more moderate exacerbation in the last year or 1 hospital admission, the suggestion is to start with the LABA/LAMA, except if the patient has high blood eosinophils or high risk of exacerbation, then an inhaled corticosteroid combination is suggested. They also go forward and say there is a follow-up for this. So you have to assess the patient. As you know, management of COPD is not just a one-shot deal. You always have to bring them back and reassess. And here you go by treatable traits. If they're mostly symptomatic but no exacerbation, then you need to maximize a bronchodilator. And also look at this recommendation. Consider switching device or delivery system, because some patients, even though they are on both LABA and LAMA, they may still benefit from a change in the delivery system if you think they're not taking their inhaler correctly. And investigate and treat other causes of dyspnea, as you see. If they have exacerbation, then the suggestion is to escalate to a triple therapy, especially if their blood eosinophil is more than 100, or considering other potential agents like roflumilast if they have severe disease, or azithromycin 3 times a week for people with recurrent exacerbation. And in the future, we have new drugs. I'll talk about one, ensifentrine, which was just approved in a nebulization platform recently by the FDA, and maybe in the future, if they have high blood eosinophil, you may consider biologics in that patient population. So this is a summary of what they suggest we use with pharmacologic therapies. What we know about the therapies for COPD have really been very enlightful. Bronchodilators are the cornerstone for treatment for this disease. Naturally, these patients have airway obstruction. They have tons of air in the lung. The problem physiologically is they cannot exhale the air. They inhale and it keeps inflating the lung, the diaphragm gets flattened, they become exercise tolerant. So what we're doing with bronchodilators, in a literal way, we're deflating the lungs. We're not pushing a needle in it, but we're deflating the lung by opening up the airway. And in fact, bronchodilators mainly are, as the name implies, open up the airway, but they may have other potential important effects, particularly anticholinergics, where they can improve the ciliary secretion, mucociliary clearance, and there is potentially, at least this is more in sort of in vitro studies, may have potential inhibition of viral activity. They may have, again, this is also based on in vitro studies. I'm not claiming that all bronchodilators have anti-inflammatory effect, but there's some data, at least in vitro, that they may do that. Now, when it comes to bronchodilators, there's no question that the anticholinergics are the strongest bronchodilator in COPD. beta-2 agonists are very important. And in fact, combining beta-2 agonists and anticholinergic is the way to go if patients are very symptomatic. And why is anticholinergic important? Because acetylcholine, as you know, the neurotransmitter, plays a major role in COPD pathogenesis, including effect, of course, on the smooth muscle cells. That's the important thing. M3 receptors are important ones to block by anticholinergic. These are mainly present on smooth muscle cells. But there are other muscarinic receptors on epithelial cell, mucous glands, and other cells. Although they're much less studied, anticholinergics play a major role. And obviously, when it comes to anticholinergic, you have short-acting agents, you have long-acting agent delivered through dry powder inhaler or soft mist inhaler, but also nebulization as well. I chose one study. Revefenacin is actually the only nebulized once-a-day anticholinergic approved in the United States. What's interesting in this study, Sanjay Sethi, a good friend of mine from Buffalo, New York, published this paper where they looked at the pivotal studies with revefenacin. And in their population, about 50% of patients were on other bronchodilators, like a LABA or even LABA-ICS. What's interesting, when they looked at revefenacin given once a day, and the dose is 175 microgram, the effect on lung function, and here this is effect on lung function, and effect on the score, which is SGRQ, which, as you remember yesterday, we talked about, that's a quality of life score. When you look at whether the patient was on LABA or LABA-ICS, or whether revefenacin was given alone, actually didn't make a difference in improving lung function. So once a day, revefenacin did the good job by itself, although if patient was on LABA as well, they of course improved as well. And then when you look at SGRQ, the SGRQ improved significantly, meaning quality of life. The score, as you remember, SGRQ, the score, when the score goes down, means the better quality of life. Well, obviously, combining bronchodilators is something that we are used to when it comes to short-acting agents. And now we have data to show that you add LABA to a LAMA, you get possibly a synergistic effect. And there may be some molecular crosstalk. I'm not going to bore you with that. Dr. Panettiere can tell us more about that. But there is definitely a potential synergy because of crosstalk between the cholinergics and receptors and the beta-2 receptors. Although they're present on smooth muscle cells, we're blocking the M3 receptor, but we're activating the beta-2 receptor. And the reason that they work better is that you may be able to use a lower dose to get a better effect. And so that's why there's been several studies and of course, guidelines. This is the official ATS guidelines a few years ago, where they actually did a systematic reviews, and they found that adding a LABA to a LAMA in patients who continue to be symptomatic has a better effect than just using one bronchodilator alone. They also had other condition recommendation on ICS, which I won't go through right now, and I'll tell you what GOLD suggests when it comes to ICS. So what about ICS? You know, we heard a lot about the NTM, and they scared the heck out of us with ICS can increase risk. But ICS are very important drugs in COPD, especially in high-risk exacerbators, especially if they have what we call type 2 inflammation, like depicted by high blood eosinophils. And this is based on epidemiologic studies, but also clinical trials. So right now, there's a strong support to consider adding ICS, meaning adding it to LABA and LAMA. And actually, GOLD suggests that if you're going to use ICS in COPD, that you shouldn't use LABA-ICS alone. You should use triple therapy. They actually removed the LABA-ICS from their armamentarium in COPD. Of course, in asthma, it's different. But these are the patients where you should consider ICS addition if patients have a high risk of exacerbation, high blood eosinophil, or of course, if they have asthma COPD overlap, you should treat them with ICS up front. Consider using, and this is a borderline, if they continue to have symptoms or exacerbation and their blood eosinophil is above 100, there is really no good rule for people with blood eosinophil less than 100 to add an ICS in COPD. There may be increased risk of pneumonia, as you know, in these patients. And of course, if they have underlying mycobacterial infection, as we heard earlier, it's something that we should not attempt to use. And there's been several trials. We've been involved in these trials. This is the pivotal trials in the United States on both a DPI and an MDI using triple inhaler, whether it's a DPI on the right or an MDI on the left. Triple inhaler, ICS LABA-LAMA, is better than LABA-LAMA alone, or a LABA-ICS alone in reducing exacerbation in high-risk patients. And not only that, but there's been some data to suggest that there is an effect on mortality in both the ethos and the impact suggests that, and also the GOLD now has a table, they added triple therapy as a potential drugs that can reduce mortality, although these were secondary outcomes in these clinical trials. Now, obviously, other options for reducing exacerbation are PDE4 inhibitors. There's only one right now that we have, at least orally, and this is roflumilast. The problem with roflumilast is GI intolerance, so you have to build it up if you're going to use it. I usually give it every other day, first week or two, if I use it at all. And there's some good data to show that those who respond best to roflumilast are those who have been hospitalized, who have chronic cough and sputum. They have to have chronic bronchitis to respond based on large phenotype studies that were done. Other things like macrolide. Of course, you have to be very careful with macrolide in this population who have underlying cardiovascular disease. You also have issues with hearing loss. You have to send them I usually send them for audiometry. But there is a good data. This is an NIH study showing a reduced 30% reduction in exacerbation when they used azithromycin 250 milligram once a day. In this study, I usually, if I prescribe it, I give 500 3 times a week, just like we use that in bronchiectasis patients. So these are options, but let's not forget the options are okay, but we cannot just put the patient on treatment and forget about him. This is a very important slide because it just reminds us, these patients, especially those with high risk of exacerbation, they need to be seen again. We have to review their symptoms, their vaccination status, but also very important, and I'll talk about that in a minute, their inhaler technique, the exposures, other things, and then readjust treatment. So let's come back to my patient, Bob. Well, when we ask him more during the history, he admits that he had a history of stroke, but he recovered. Although his wife says that she's concerned that he doesn't remember very well, his memory is not as normal, and that maybe he's not using the inhaler correctly because when she watches him, she doesn't think. So we do test in our clinic. I don't know if you do it, but I have the toy box with me, and I have an educator, and we have placebo inhalers, and we actually ask the patient to demonstrate. Of course, videos are good and handouts are good, but there's no better than doing it in front of them and seeing if they do it correctly. Well, the fact is, this patient was on ICS LABA on a dry powder inhaler. You have to be very careful, although he's not very old, but he had a history of stroke, you have to be careful in prescribing an MDI, a DPI, in somebody who has cognitive dysfunction, or if it's a very, very old patient who doesn't have enough inspiratory flow to disseminate this dry powder inhaler. It turns out that both his MDI technique and DPI technique included critical errors. Well, he's not the only one. In fact, many studies have shown that up to 90% of patients, when you test them correctly, they may have one critical error in using an inhaler device. An MDI has 9 steps included if you want to use it correctly. There are 2 critical steps, which often my patients don't do it right. One is the breath hold, obviously, but also the inhalation and the actuation inhalation, the coordination. Sometimes spacer devices may help you overcome that, but not in every patient. With dry powder device, as I mentioned, peak inspiratory flow rate is very important. If you have the check device that you can check, but some patients are too weak to generate enough peak inspiratory flow rate, like about 30 liters per minute, to take a dry powder inhaler. And these are some general recommendations that we should do. It's a two-way highway, and I'll talk to you about shared decision-making towards the end of my talk. This is something that's very important, not only with the patient, but sitting down with their caregiver is very important. And we do have the luxury of having different delivery systems, that the choice is there. In fact, this is taken from GOLD, and GOLD suggests that the device, the choice of inhaler, has to be individually tailored. I talk to my fellows, this is personalized medicine. It's not just using expensive drugs. It's using the right device for the right patient. And there are different platforms, so you have to think about those. This is a very nice review. Don Moeller is a very good friend of mine, and he actually has retired now, semi-retired, but he's published several papers on delivery systems. And this is a nice review, along with David Halprin from the UK, recently published. He really reminds us that there are some device attributes that makes us pick the right delivery system, but there are patient factors. You can look at them: cognition, manual dexterity, peak inspiratory flow rate, and that makes you, pick one versus the other. Naturally, nebulization is very easy. It's a passive sort of delivery system. But the fact is that we don't have too many drugs that come in the inhaled delivery. Another very nice paper by Moeller in our journal. I'm editor of Respiratory Medicine, so I always love to see papers. And if you all have some papers, send them to me. Of course, I'll have to send them for peer review. But this is published in Respiratory Medicine. And he suggests an algorithm how to pick which delivery system to use. The manual dexterity, peak inspiratory flow rate, and if they have good peak inspiratory flow rate, they don't have cognitive dysfunction, then a DPR, SMI, or MDI is fine. But if they have, then a nebulization. And cost is an issue too. Nebulization is covered by Medicare, Part B, mostly. So that's another thing to think of. So actually it takes a village. When I say it takes a village to get these patients to adhere to the management, not just the pharmacologic management, to the management so you can see education is very important, setting treatment goal, asking about device preference, use patients to complete treatment course. All these are important. When it comes to pulmonary rehab referral, you need a person who will adhere to 3 times a week going in for 2 months to a pulmonary rehab program. I worked with CHEST on several things. I mean, I've been working with CHEST for many, many years. But one of the things we worked on is this COPD shared decision-making sort of handout. You can see that there are several steps that you can utilize when it comes to talking to the patient and involving them in their care. A written action plan may not be a bad idea. This study this is a Cochrane review where they found that a written action plan may actually help decrease hospital admission when it comes to patients with COPD. So yes, self-management is important, but you have to be very careful from those patients who are overconfident, because they may actually start treating themselves and ignore the fact that they need to call you or go to the emergency room. So it goes both ways. If you're confident the patient knows what they're doing, build up an action plan. You may give them a short course of oral steroid or antibiotic to keep in their medication cabinet. But if you're not sure, better not to, and better let them call you or go to emergency room if they have problems. With all that, we have good drugs, but sometimes it fails. I showed this slide yesterday. Triple therapy certainly is very important. If they're delivered correctly, if they're taken correctly, there's still about 50% of patients will still exacerbate despite triple therapy. And that's why we are now going further to looking at, okay, can we phenotype or endotype these patients, and can we maybe use some of the omics out there to help identify. So this is the era where we're looking at things beyond what we have right now. So emerging inhaled therapies, I won't talk about all these. I will share with you a exciting new drug that is approved now in the United States through inhaled delivery system through the nebulization. That's ensifentrine. And basically ensifentrine, and Dr. Make showed you some of these data yesterday, but briefly, it blocks both PDE4 and PDE3. Blocking PDE3 causes bronchodilation. This is a drug that is nebulized twice a day. And in the clinic, and it has potentially multiple effect on the smooth muscle, but also on inflammatory cells and potentially on epithelial cells trials, including CFTR. Most of this is more basic science-based, and there's really no good clinical data yet on these. But there is enough clinical data to suggest that on lung function, in addition to underlying long-acting bronchodilator, nebulized ensifentrine can improve lung function in these two large clinical trials that were published. And not only that, but in this, even though they were small studies and short, like only 6 months, in these trials there was a decrease in exacerbation in that patient population. So this is an option that is available now as an add-on. Obviously, cost is an issue. You have to really prioritize the current treatments that we have before you jump to this type of. But again, it's a nebulized. And I talked a lot yesterday. I won't bore you again. But there are other targets that we are looking at, and these are biologics, mostly in the avenue of type 2 inflammation. And certainly, dupilumab is the most promising right now. There are studies finishing up looking at anti-IL-5s. And let's not forget the epithelial cytokines are now being looked at in several phase 3 trials. We talked yesterday in details about blocking anti-IL-5 or IL-5 receptors. The phase 3 trials where borderline and longer trials are ongoing now, both the Resolute and Matinee. We heard last week that Matinee met the primary endpoint. We don't have the details in reducing exacerbation. I showed you data yesterday about the Boreas and Notus with dupilumab reducing exacerbation and improving lung function and patient-reported outcome. And then the epithelial cytokines are now being targeted by several biologics. Again, some data are coming out from phase 2 trials. The phase 3 trials are still ongoing. So in summary, what I try to convey to you today is that when it comes to COPD, we really cannot see it the same in one patient and the other. You always have to personalize your approach. When it comes to therapy, inhaled therapies are important. Bronchodilators are very, very important, pivotal drugs in managing COPD, especially symptomatic patients. When it comes to bronchodilator, adding a LABA over a LAMA is very important in those who continue to have symptoms. And they're fairly safe and as safe as monotherapy. We talked about the fact that choosing the right inhaler is a very important step in the delivery system in these patients. And you have to keep in mind to consider underlying cognitive function, dexterity, cost, all these, and have a shared decision-making when it comes to treatment in these patients. And of course, we're really happy that there is more light at the end of the tunnel for these patients and more novel targets being looked at. Thank you so much for attending. I want to show you how to claim CME.
Jeff, here, please focus and click on that for your CME credit. We do have an opportunity for 1 or 2 questions to Nick.
Yep. Yes, sir.
Thank you. Excellent talk. When do you favor roflumilast and when do you favor azithromycin? I personally, in my practice, use azithromycin much more frequently because it's easier to tolerate and it's cheaper. But when do you use each one of those?
So,
can you use them both?
Yeah, thank you for the question. So to some data, although again, it's based on post-hoc analysis suggesting that ex-smokers with COPD may respond better with azithromycin. Those with hospitalized COPD, with they have to have chronic bronchitis for roflumilast to work. We know that from their pivotal studies. Cost may be an issue and reimbursement, obviously, and then GI intolerance. I usually, like yourself, I usually go with azithromycin first if I use it at all. But you have to be careful, as I said. You need to look at their EKG, make sure there's no QT prolongation, and get the audiologist, because the last thing you want to see the patient coming in, hey doc, I can't hear. So hearing loss there's some concern about resistance. The macro studies that I showed you, there was some emergence of resistance, especially if patients have recurrent infections. You have to be careful about that as well. But microbiologic resistance. We use it like we do in bronchiectasis. We use it more as an anti-inflammatory than anti. And of course, if they have underlying NTM, you should not use azithromycin, as you heard earlier.
Great. All right. Last question.
Quick question. So the next COPD Gold conference is in November in Philadelphia. Do you think they will be putting in one of the guidelines, they will be putting in the biologics?
We don't know. I don't think so, because so far none of the biologics are approved here. Although I have to say, in Europe, dupilumab is approved for COPD, and I think their strategy. I don't sit on gold, but their strategy. They're not guidelines, as you heard. Strategies. Their strategy is to include it in the armamentarium if it's approved in one country. So we have ensifentrine approved in the U.S., not in other countries, and we have dupilumab approved. By the end of this month, we'll see if dupilumab gets approved here. They're going to be mentioning the studies because these are published. They cannot ignore them. Whether it'll be in the step-up category is another question.
Thank you so much.
Ensifentrine will probably
Ensifentrine.
get into the guidelines, but until the others are approved. What I want to do is thank you all.
Thank you.
It's fabulous and thrilled that you stayed, and everyone have a safe trip home. This concludes the program. Thank you.